Okay, we left off our last meeting discussing the divisions of the skeleton. We went through some of the bone tissue aspects, the different bone cells that we find, different items that we see in the matrix of bone. We also got into discussion about long bone, short bone, flat bone, irregular bone as well. So anyway, we're going to get into some specifics today. The axial skeleton we saw last time is the skull, vertebrae, and thoracic cage. And I think we saw this all the way back in week one when we looked at some of our information regarding anatomical terminology. Axial and appendicular were in there. So as they relate to the skeleton, skull, vertebrae, thoracic cage, and then the appendicular skeleton comprising everything else. So the arms and legs, of course, relating to the appendages. And then we've got our two girdles, our shoulder girdle and pelvic or hip girdle. And so there's a look again. This is right around where we left off last time. So we see the axial skeleton in blue and the appendicular skeleton in kind of a cream color or a white color. Okay, so we're going to look at the cranial bones of the skull. First off, we have the frontal bone, also known as the forehead. We do find sinuses in the frontal bone as well. As we go through these different bones, we're going to see a few landmarks along the way. And bony landmarks are generally one of a couple of things. When we see a bony landmark, typically a bump or a ridge or a groove, generally speaking, it's either going to be a muscle attachment site. So a tendon from a muscle would plug in typically to some sort of a bump. And these bumps have different names. Tuberosity, we'll see the word condyle, epicondyle, ridge, crest. Those kind of uh, bony landmarks that have relief or form to them that leads to maybe more of a bump is going to be typically muscle attachment or maybe ligament attachment. The other bony landmarks we'll see are going to be the opposite of bumps. They're going to be depressions. So sometimes a bump and a depression come together, and we have what's called an articulation or a joint. So bony landmarks are either muscle attachment, ligament attachment sites, so some sort of soft tissue attachment site, or they form some sort of a joint with another bone. We do see a few kind of oddball ones that don't fit into either of those categories, and that would be a sinus. A sinus is a room or a cavity, a space within a bone. And again, we've looked at pseudostratified epithelium last week. We saw the cilia and the goblet cells. They help with filtration. They help with kind of humidification factors as well. The air we breathe is generally pretty dry, so we want to humidify it a little bit, and so the sinuses help with that. Certainly the air is a little bit dusty and dirty, so we do want to filter some of that. So the goblet cells help with some of the stickum for the cilia to catch some of the particulates. And then we also, again, see a little bit of humidification below or deep to that pseudostratified epithelium. We're going to find the connective tissue in the sinuses and lining a better part of the respiratory tract. That connective tissue have a blood supply, so that'll provide some warmth as well. So sinuses generally exist to provide some warming properties to the air, because it's 98 degrees inside and it's less outside. So that air is kind of cool, especially now as we get closer into fall and winter. So the sinuses can help to warm the air before it gets too far into the respiratory tract down and toward the alveoli of the lungs. We can certainly filter and humidify the air as well. So it's good to have the sinuses open for that purpose. So anyway, the frontal or the forehead contains a couple of sinuses. We're going to see 4 bones that contain sinuses. So this is bone number 1. The frontal bone also forms the roof of your orbits, which the orbit is the eye socket. So we do see that as well. Another special feature that we're going to see, particularly with the skull bones, are what we call sutures. And a suture is something I'm sure all of you have heard of at some point, probably associated with medical, maybe some sort of a stitch or stitching that took place because of a wound or because of a surgical procedure. We would see sutures. So sutures generally bring two sides together. So what we have with the skull are a few different bones, and those bones are going to be fused together by sutures. And these sutures are kind of jagged lines that we'll see coming up in some of our illustrations and images. But the frontal bone connects with the crown bones, which we'll see are called the parietal bones, with a suture called the coronal suture. And that suture is immovable. As far as a joint goes, a joint is two bones that are coming together. Any two bones that come together make a joint. We'll see that later as well. Well, I guess we're kind of seeing it right now. This is your first joint too, then. We've got a bone, the frontal, coming together with a parietal bone of the top of the head. So it is an immovable joint. We don't think of it as a joint like we'd see, with our shoulder or our elbow. Elena asks the sinuses also. Yeah, those are the ones for sinus infections. Yeah, generally speaking, the skull bones and the and I have a couple of illustrations that'll show all of the sinuses coming up. They're pretty deep in, not the frontal bones. The sinuses of the frontal are the largest, I would say, and they're also maybe closest to the surface. You have a couple of sinuses underneath the eyes, or the orbits of the eyes, kind of the bone that makes up the floor of your eyes, called the maxilla bone, which we'll see later. That's part of the face. But you see sinuses there, and then there are a couple more bones kind of behind the eyes that are going to have sinuses, which right? If you have congestion in your sinuses, you may feel it in different spots depending on what sinus is infected. You may have a sinus infection more in the frontal sinuses. It may creep more into these maxillary sinuses, or they could be, kind of, when you have a cold or a sinus infection. Uh, Other allergens can irritate the sinuses certainly too. So it may not be an infection, but like an inflammation. So you could have sinusitis without an infection. It's a response to allergies, a reaction. Environmental factors certainly, but yeah, the eyes can kind of feel puffy. You can feel pressure kind of behind the eyes sometimes, or certainly in the nasal cavities. Everything feels full. But yeah, those are the sinuses, and when air passes through the nostrils, the nasal cavity, we'll see when we get to the respiratory system. We'll see a little bit of it certainly today with the skeletal, but the nasal cavity is actually pretty large, and it's also lined with that pseudostratified ciliated epithelium. So when we bring in air through the nasal cavities are basically going to kind of distribute the air through the different sinus cavities, and what the air just kind of circulates in the sinuses, and then ultimately ends up heading down towards the lower respiratory tract. And so if we can enable the nasal cavity tissue lining, the sinus cavity tissue linings, to be open and do their jobs, then it puts less of a strain on the ciliated epithelium of the trachea, and then we head into the bronchi, and that tree of the lungs. And so the more we can do with the upper respiratory tract to enable the lower respiratory tract to be doing better distribution of air, then of course the healthier we're going to be. And plus, when this is clogged up, we still have to breathe. So then we start breathing in through the mouth, and that can we don't have pseudostratified ciliated epithelium in the mouth, and so anyway, particulates, and so it triggers the lymph nodes like the tonsils to maybe be a little bit more active in regards to filtration of the air that's coming in. So then that can lead to a whole nother group of problems, right? Like maybe tonsillitis or some sort of pharyngitis or laryngitis. And if it gets really bad, it can creep all the way down into the bronchi, and you can get bronchitis, and then hopefully it stops there and doesn't get too deep into the lung tissue. But yeah, the skeletal. So there's another how the skeletal system works with other body systems. Skeletal system works with and it is connected with the respiratory system. So we'll see the we just did the upper respiratory tract, and respiration really begins in the nasal cavity of the skull. Let's see. Okay, and then the nothing too special about the next two bones. With the next bone, you have two of them. The parietal bones are on top. That alone makes them special, right? They form basically the crown of the skull. They're kind of the hot spot where all bones of the cranium have some sort of connection with these two parietal bones. When I say there's nothing special, I suppose I mean there aren't any sinuses. We don't see much in the way of bony landmarks other than sutures. So the parietal bones, you really are going to relate to having a lot of sutures associated with them. The two parietal bones themselves form sutures on the very top or the very crown of the skull. And those suture lines are going to go this way, and we would call that a sagittal suture. Because again, sagittal, remember, divides you into left and right sections. So the sagittal suture goes right down the center of the crown of the skull. And again, we're going to have the left parietal and the right parietal fused together by those sutures on the top of the head. And when we're coming through the birth canal, those sutures are not, obviously, they're not sealed together quite yet. At least we hope, because that allows the baby's head to be, again, more of a football shape than a basketball shape. So football is a little bit smoother delivery than a basketball. So no matter what's being delivered through the birth canal, it's not smooth sailing for the most part. It's going to be so our skeletons are designed in a way to make it as smooth sailing as possible. So of course, as the baby, within hours, right, the head starts to kind of decone a little bit, and everything starts to mold a little, over the first few weeks, and over time, all of those sutures are going to fuse together and become more or less immovable joints. So anyway, we already saw the frontal coming together with the parietal bones, forming that coronal suture, and then the two on top form the two parietal bones, forming one suture across the center, called a sagittal suture. And then the next suture that we see in the back of the skull, or the base of the skull, also goes with the parietal bones. The next bone, so we'll get to the occipital in a second. Before we do, we're going to do the bones on the side of the skull that make up the side of the cranium. Those are called the temporal bones, also maybe known as like the temple bones. But they actually go a little bit further back. The temporal bones are extremely complex as far as their shape goes, as far as the amount of bony landmarks involved. So we'll spend a little bit of time coming up on the temporal bone, because it is a little bit more complicated than the frontal and the parietal, really than any of the bones of the cranium. The next cranial bone we'll see is the occipital bone. That forms the base of the skull as well as the back of the head. So the back of the head and then the base of the skull. Your skull sits on top of your vertebral column, and it's the occipital bone that's going to articulate or be connected with your vertebral column. Okay, so that has a couple of bony landmarks that we'll see. We also see a large hole in the occipital bone. That's going to be where the spinal cord leaves the brain and heads down into the vertebral column. So we do see a large hole with the occipital bone, and that a hole in a bone, as far as bony landmarks go, again, that's in kind of the other category with sinuses. Remember, most bony landmarks are going to be muscle attachment or tendon attachment, ligament attachment, some sort of soft tissue attachment, or they're going to form some sort of a joint. Whereas the other category, sinuses are form a room, and then we also have holes in bones. So we'll see that coming up soon. Those are called foramen. It's F-O-R and then amen, foramen. And a foramen is simply a hole in a bone. So again, we'll see that coming up in more detail shortly. But one of the largest holes in a bone of all of the bones of the skeleton is going to be in that occipital bone. We do have one other foramen in the pelvis that's larger than the foramen of the occipital. But for the most part, it is one of the largest holes in a bone, or largest foramen of a bone. So we'll look at the occipital in a little more detail as well. We'll certainly see it again when we get to the vertebral column. And then we have the sphenoid bone. And the sphenoid bone is going to be more or less kind of inside of the skull. It forms kind of the floor of the skull, of the cranium specifically. So the cranial floor is in essence formed by this sphenoid bone. This is our second bone now that we see with sinuses. And again, it doesn't really make much of an appearance superficially. There's a slight bit of sphenoid that's going to be right basically between where the frontal kind of ends. There's a little bit of sphenoid, and then the temporal bone begins. So you don't really get much of it. It is one bone. So even though there's a kind of a left side, right side of the sphenoid, it is one bone. And it has from the bird's eye or from a superior view, if we were to take the skull cap off and look and remove the brain and look down into the skull, we would see what looked almost like a bat or butterfly shaped features of the sphenoid bone. So they call them the wings of the sphenoid. And then kind of the body of that butterfly we'll see has kind of a little saddle to it. And that saddle is grooved out. We're going to see that's where the pituitary sits. And the pituitary is the master gland of the endocrine system. That's a kind of a little pea shape or a little blueberry that kind of dangles and is connected with a little stem off of the brain. And that pituitary sits right inside of the sphenoid bone in this little tiny groove or depression called the sella turcica. So that's listed there, the second bullet under sphenoid bone. So again, it's kind of a bat-shaped bird, bat-shaped butterfly-shaped bone. Again, kind of forms the floor of the cranium, and does have a couple of sinuses as well. Okay, and then the ethmoid bone within the cranium, also kind of along with the sphenoid bone. The ethmoid bone is a little bit anterior, a little bit in front of the sphenoid bone, and it basically kind of sits right behind the third eye. So if you, it's a ethmoid is completely internal. It forms kind of like the roof of the nasal cavity. So when we go up into the nasal cavity, the roof, I guess the ceiling of the nasal cavity. So if we're going into the nasal cavity, the ceiling of the nasal cavity slash roof of the nasal cavity is going to be formed. We'll see images of all of this in your visible body that you're going to spend the next 10 days or almost 2 weeks on getting acclimated to these bones. Again, this is just a verbal introduction, just an audio introduction to the black and white of it, if you will, of these bones. So if you can certainly go back and listen to this if you want, or go back and look in your slides when you're doing your visible body work, or when you're looking at these bones. Again, go out and get a skeleton if you don't already have one. The lid may not come off and you may not see some of what I'm talking about, but in the visible body you will, certainly. But the ethmoid bone is very small. It's the roof or the ceiling of the nasal cavity, and it actually is an area where we see scent molecules. So when you smell something, you're getting little tiny chemical molecules or scent molecules that actually travel through the nasal cavity and pass through the roof through a bunch of little perforations or holes, and those perforations actually go through the ethmoid bone. There's like a little plate that we'll see that kind of separates the left and right upper portions of the nasal cavity. That's part of the ethmoid bone. And then once we get up into the skull, we're going to have two little kind of Q-tip looking nerves with nerve bulbs that sit kind of right inside and right along with that ethmoid bone. So when smell molecules go up into the nasal cavity, they're going to pass through the little pores or perforations of the ethmoid bone en route to what we call the olfactory nerves in the olfactory area that'll eventually go to the olfactory region of the brain. So that sense of smell is going to pass through the ethmoid bone. There also happens to be a couple little sinuses associated with that ethmoid bone. So we'll see that coming up as well. There's so it forms the anterior cranial floor. So again, just kind of the front of the cranium, the ethmoid sits there. The sphenoid forms a better part of that kind of cranial floor as well. But the ethmoid kind of fits right in just anterior to the sphenoid. And then we see the medial walls of the orbits of the eyes also are formed by that ethmoid. So again, it's basically kind of right through that third eye area, and then again, the roof of the nasal cavity. And again, that upper part of the nasal septum. And then once we're actually in the skull, there's a plate called the cribiform plate. The crib is where the two olfactory bulbs, the little babies that lay in the crib of the ethmoid bone, are the olfactory nerve bulbs. So again, that's where scent is passing through. So we'll see all of that shortly in more detail, or you'll see that shortly like I say, over the next couple of weeks as you work on visible body as well. The frontal bone, we see there. We don't really see much of the other bones. We see a little parietal on the sides. We see a little bit of the temporal on the sides. And again, there's that sphenoid just barely making an appearance as well. The eye orbit, each orbit has 7 bones, basically, of the skull and face, of the cranium and the face coming together. So each eye orbit is 7 different bones kind of fused and coming together in a central location. So we'll see that in more detail later as well. The ethmoid, you can see the ethmoid forming that nasal septum there. And then a couple of other they're called conchae. A conch is kind of like a conch shell, kind of a curve. Um, So anyway, just know the ethmoid is forms the nasal roof and the nasal septum, and then we also can find the ethmoid from a superior view, looking down at the anterior section of the floor of the skull, and it's also again where we find a couple of sinuses. So a lateral view of the skull, we can start to see some of the suture lines that I mentioned a little bit ago. We see the frontal bone connecting with the parietal bones, and we can see those that coronal suture line there. Then we come back to the occipital bone, or the base and back of the head, base of the skull, back of the head. We can see another suture. We call that the lambdoid suture, kind of an oddball name. That's a Greek letter, lambda, and the lambda is the Greek letter for L, and a lowercase lambda kind of looks like this. Oops, without my thumb in the way, kind of looks like this. And so that suture, that lambdoid suture, kind of looks like a point, or kind of an arrow. So that's where it gets that name, lambdoid suture. Coronal suture, and this doesn't show because we're not looking at a bird's eye view. We can't see the sagittal suture, but it is there. And then we've got another one called a squamosal suture. Remember, squamous means squashed or flat. So we do have another suture where the parietal and the temporal bones come together, called the squamous or squamosal suture. Those are the main ones, I suppose. Those are the main four sutures, going from anterior to posterior: coronal suture, sagittal suture, lambdoidal suture, and then on the sides, we've got those two squamosal or squamous sutures. Now, while we're on this spot, and again, you can see from here, the parietal bone doesn't have much going for it other than it's a very centralized spot for all of these other cranial bones or skull bones to connect. The occipital, we'll look at a little more closely here in a few minutes, but this is a good time to take a peek at some of the features of the temporal bone. The temporal bone has a lot going on. As you can see, this color-coded bone or skull is nice. We have these in face-to-face lab as well. And again, I encourage you, if you have the time or the energy or the ability, if you want to get onto Elkhorn or Racine or Kenosha campuses, to check out any of the skulls at the Learning Center, any of the bones at the Learning Center, by all means, let me know, and I can get you connected with the right people. Or you can just go in. If you know where the Learning Center is, you can certainly call or ahead, or email ahead, or just show up during kind of normal hours, between probably like 9 and 5, I would imagine they're open. So anyhow, we have color-coded skulls. That was my point. So here you have one, which is kind of nice. Of course, they're not color-coded in the real world, but we do see in the real world, we would be able to look for the sutures as the landmarks to distinguish the bones. Okay. So anyway, we can see one thing right away with the temporal bone. We see the ear hole. So we have an ear canal, or what they call a meatus. It's basically a meatus is a small, here's the spelling, meat, like meat that you eat, with an with an us on the end, meat us, but with an A there. Meatus. That's a canal in a bone. So that's the external auditory or acoustic meatus of the temporal bone. And then just inferior and a little bit medial to that, we have this little process called a stylus or a styloid process. Styloid means kind of like a needle point. And then a process is just what it sounds like. It's like a protrusion or something that kind of comes off of a bone. So we do see the word process occasionally as we go through the skeleton. So there's a process there, kind of sticks out. That's the stylus or styloid process. Notice again, we're right at the kind of the posterior edge or border of the mandible. And then right here is going to be that bump that's behind your earlobe. So behind your earlobe, there's a hard bump. That's called the mastoid process. Some of you maybe heard of that. Some of you or your children or know folks who have had what's called mastoiditis. So that the mastoid process, being that it's a process, remember, most of these are bumps or grooves, these landmarks. Both of these are bumps, so they call them processes. They don't call it the mastoid bump, although we do. I mean, your patients might talk about the bump behind their ear, so that's what they're talking about. That's going to be a muscle attachment or ligament attachment site. This particular and by the way, the bigger the bump, the bigger the process, the bigger the tubercle or tuberosity or condyle, whatever it is, the bigger that bump, the more you're going to have, the more muscle you're probably going to have, the bigger muscle group. So the fact that this mastoid process has a pretty good size to it versus or compared to or relative to the size of the styloid process, we're going to see a larger muscle group attached to this big bump. And in fact, the muscle of your neck, you have one on each side, they kind of form there's kind of a tendon that sticks out there, and that muscle travels up into that bump. You have one on each side. That's called it's a long name, so you're going to learn another muscle as we kind of think about moving forward. We do bones and muscles kind of together. I think the most obvious body system that goes with the skeletal system would be the muscles. So kind of as we go through this system this week and next week, we're going to see again that these bumps play a role with musculature. And oftentimes a muscle is going to be named for what it's connected to. So if we understand some of the muscle and bone terminology, it all makes sense as being interconnected. So anyway, that muscle is called the sterno, meaning sternum, cleido, meaning clavicle, mastoid muscle. We abbreviate it SCM because it's such a long word, but the M of this big muscle means mastoid. So it tells us, the muscle name tells us where it's connected. So if you know a little bit about your bones, you can know quite a bit about and make some pretty safe assumptions about where some of these muscles are going to be connected. So anyway, that's why we spend a few minutes on some of these bumps, less time on others. So anyways, mastoid process. Again, processes either form a bump or either form a joint or they are a muscle attachment site. So these two happen to be muscle or ligament attachment sites. We're going to see some ligaments that attach to the styloid that kind of anchor the what's called the hyoid bone. It's a little horseshoe bone in the throat region. So we'll see that coming up later. Anyway, so those are three hot spots right there for the temporal bone. The ear hole or the auditory meatus, the styloid or needle-like process, and then this bump behind the ear called the mastoid process. There's another spot. We don't label it. We label it later. But if we were to remove the mandible or remove the jaw, we would see that there's a groove in the temporal bone where this bump of the mandible is going to fit. So this is a joint, right? We've got a bone coming together with another bone. And this particular joint is very problematic for some folks, and maybe some of your children may have some tinnitus or ringing of the ears. They may have some teeth grinding issues. They may be diagnosed with something called TMJ disorder. And that just means temporal, so the temporal bone, and the mandibular, or the mandible bone. So we say mandibular relating to the mandible. So temporomandibular, and then the J is for joint, TMJ. So all of you and all of us, we all have a TMJ, but we may not all have TMJ disorder, which again is sometimes it's just acute. Sometimes after I've done a lot of talking, which I can't imagine that ever happens. But there are occasions when I do talk a lot. And sometimes at the end of the day, after a lot of talking, my jaw may be a little bit worked out, and there may be a little bit of sensitivity, or I may get a little pop or a little click or something from that area. That's just some sort of an acute, certainly from overuse, right? Joints become inflamed, sometimes just acutely inflamed, typically from overuse or repetitive use. So some folks chew a lot of gum. They come into the office, and they might have headaches, in through here, temporal lobe kind of headaches. Well, the muscle that closes the mandible, or we say elevates the mandible, closes the mouth, for chewing and speaking, it's a large muscle. You can almost see the ridge where that muscle would anchor right along here. It's a very large kind of a pennate, almost like one of those fans, that you get. You can get them at the Dollar Tree now. They used to get them as kids, you have to go to like the Science and Industry Museum. You get kind of, or those cool fold up fans. They have like a dolphin or something on them. But anyway, it's kind of like a fan shape. They call it pennate. And so that all kind of converges into this one spot kind of down here on the mandible. And so folks who chew a lot of gum or grind their teeth or grit their teeth oftentimes will have some headaches. They'll have some sensitivities up through here because, again, of that muscle overworking, causing some tension on this area. So anyway, TMJ disorder. Sometimes the joint is just a little bit out of whack. It might be a little bit too far forward or a little bit retracted. So protracted or retracted. It might be off to the side a little bit. Okay, so any number of reasons why, and those weren't so subtle, but it could be something that's really subtle that's playing a role in wreaking havoc, maybe with one side of the head or the other. Maybe one's overcompensating, and that's why they're there. So at the clinic or at the doctor's office. So anyway, sometimes they may need some orthopedic help. They probably don't need surgery. Oftentimes physicians will prescribe some sort of a bite block or something to help with the grinding, or a dentist or an orthodontist might have them have a bite block. But that doesn't really solve the problem. That's treating a symptom, right? The problem is something much bigger. We don't, because if you're still grinding your teeth, but we just put a little buffer in there so it doesn't grind the teeth down, it's not so loud or whatever. Well, they're still grinding the teeth. There's still an issue. So we need to figure out what it is. Some could be stress related, usually is, environmental consumption related, caffeine can get that going, stress, gum, whatever. They could have had some sort of physical trauma that has led to that, certainly, as well. So the temporal bone plays a lot of, so an issue with the mandible could lead to an issue with sound and hearing and perceptions, could lead to inflammation of the neck musculature, can certainly lead to some issues. I mean, these are very close together, right? The TMJ and the SCM insertion point, okay, for moving the head. Okay, all those actions come from that muscle and from that area. So the other thing we have, lastly, with the temporal bone, and then we'll move on. You can't really tell here because it's a two-dimensional screen, but in real 3 dimensions, this little spot right here, this is another process. They call it the zygomatic process of the temporal bone. But for us, we call this whole little thing here the zygomatic arch. So the zygomatic arch is formed by 2 bones, one being the zygomatic or cheekbone, which we haven't gone through yet, and the other being, and primarily being, the temporal bone. So you can see that zygomatic process of the temporal bone. So that actually kind of juts out a little bit, and so there's a space kind of in between I don't know why I'm using my finger. There's a space right here in between this area where where a muscle can drop right behind this. So you can actually go behind this, and that's where that muscle up here, we call it the temporalis muscle, kind of goes behind the zygomatic arch as it plugs into the mandible. We see this on, if you have pets, especially cats or dogs, um, they usually have really big kind of zygomatic arches or cheeks relative to the rest of their face, right? They have these tiny little, the cat especially, right? They got these tiny little mandibles, but they've got these huge zygomatic arches. And again, they, the big cats, right? They're like a lion or a tiger or a cougar or something, they actually eat bone marrow. So they have to be able to crunch down really hard with their molars to be able to break into bone. We would see giant zygomatic arches on like an alligator, right? A crocodile. You look at a skull of an alligator or a croc, and it's just got huge space for muscle to go through there to connect to the jaw. Okay. Nice artwork, by the way. That was good. Thank you. Yeah. So if you're using this as share, this is Sharedy, right? This slideshow, you can get to it. So some of you, as you're doing this, you certainly um, can make notes or marks on there. Somebody figured that out. Okay. So anyway, that's it for zygomat, or for the temporal bone, and really for the bones of the cranium, except for the kind of the uh, internal view, a superior view from looking at the inside of the skull with the brain removed. We can really get a good look at a couple of those bones that maybe were a little more difficult to conceptualize. We see the first one, we'll go from back to front or posterior to anterior. We'll start with the occipital bone, kind of the back of the head or the base of the skull. And again, I mentioned before, we had a large hole in that one we called a foramen. So there you can see foramen. Okay. And they call it magnum. Magnum means big, right? Magnified, large. Uh, so if the foramen magnum, large hole in a bone. So again, probably one of the, not probably, this is one of the largest foramen in the body, probably second largest. We'll see, again, bigger one down in the pelvis. Okay. There's another area of the occipital bone, a bird's eye view, or a worm's eye view. So looking at an inferior view, we'll see that perspective in a few minutes, because again, the occipital bone is the bone that sits right on top of your vertebral column. So we're going to see a couple little kind of bumps or condyles when we look at, when we flip this over and look at the underside of the cranium. Okay. So then we end up with the wings of the sphenoid. Okay. Again, it looks kind of like a bat or a butterfly. Okay. And then this is that saddle where the pituitary gland sits. We called that the sella turcica. Okay. And then we see then the kind of the anterior floor is going to be the ethmoid, just a little bit of it. It's a small bone. There's not much to it. The bulk of this is going to be sphenoid and frontal coming together. And then we have a little bit of ethmoid there, and you can't really tell, but again, the cribiform plate and the crista galli, this is going to be kind of like a spiny, not spiny, kind of like a wall, like that sticks up. It goes from about right here to back here. This is going to stick up a little bit, almost like I don't know, a couple of centimeters. And then again, along each side of this wall is the crista galli. That's we're gonna find those olfactory bulbs, or those little Q-tips. Okay? There's going to be a little end of a Q-tip going to come down. It's going to plug into the brain. There's going to be another one on the left side is going to come in, it's going to plug into the brain. Okay, so that's going to be for smell. So ethmoid relate to smell. It's the roof of the nasal cavity. Also has sinuses. So there are a couple little sinuses, very tiny, in the ethmoid bone. We have a couple sinuses within the sphenoid bone, and then it doesn't show, but there are going to be a couple of sinuses as well in the frontal bone. So of your 4 sinuses, 3 out of 4 are going to be part of the cranial bones. Okay. The 4th one we'll see shortly is going to be part of the facial, okay, facial bone. All right, and then lastly, the inferior view, skull viewed from below, the worm's eye view, going back to the occipital. Again, we see the big hole, the foramen magnum, and then we have these 2 little condyles on each side. The other couple of items that we notice as we go now, well, you can see the temporal bone and all of its glory there. And you can see the sphenoid here. Now the rest of these bones in front here, this pink one and yellow one, got kind of a grayish colored one here and this green one. These are going to be part of the facial bones. So that's coming up, but I don't think I have this illustration in later. So I do want to bring this up. Just kind of your introduction or our segue between the cranium and the the cranium and the facial bones. All right. So working from back to front or from posterior to anterior, kind of nestled in here is a bone called the vomer. Vomer means plow, and we're going to see the vomer in more detail coming up. This is a very tiny portion of the vomer. So it's kind of like, it's just above the soft palate at the roof of your mouth. So when we're at the roof of the mouth, so the very anterior most, the front of the roof of your mouth, you put your tongue up there, push on it. Okay. That's part of the maxilla bone. Okay. That's part of the maxilla bone. We call that the hard palate. And then as you move your tongue back or posterior, okay, it starts to get a little bit softer, right, toward the back. Well, right before it starts getting softer, you still kind of hard back there. That's called the palatine bone. So the maxilla bone, which maxilla is basically your kind of your upper jaw, that forms your upper teeth. We've got a couple sinuses there. Okay, that's the maxilla bone that also forms the roof of your mouth. The posterior part of the roof of your mouth that's still hardened, that's called the palatine bone. Okay, so together it's called the hard palate. When you go further back, you get to what they call the soft palate, right? Kind of that is that fleshy kind of soft part, and everything kind of starts heading south, right? It's got the little dangly, we call it the uvula back there that kind of dangles, and it's good. So there's kind of some flesh there and a little dangly jobber. That's called the soft palate. Well, if you go past that soft palate, you actually can go up into the nasal cavity, right? So that is this little area right here. So we can end up traveling into the nasal cavity by going beyond and then back up and around. So, so anyway, the vomer is going to be, we'll see that coming up as part of the nasal, makes up part of that nasal septum that we see at the floor. Kind of the hard palate and the vomer kind of, and the part of the maxilla, they kind of form not only the roof of the mouth, but they're the floor of the nasal cavity. So we kind of have like a kind of a 3-story structure here. We've got the frontal aspect of the cranium where the brain sits, and then we've got the nasal cavity, Okay, that's the second floor. So we got the third floor, the second floor, and then the first floor is the oral cavity or the mouth. All right. Who knew there was so much underneath all this flesh? By the way, we spend the most time on the skull because there are the most bones, and it's probably the most complicated of all of the bones of the body. So we're almost done with skull. We do have a few facial bones to look at, and then we'll keep the train rolling here. Um, from within, here's a mid-sagittal slice. We've removed half of the skull, so you can see kind of the inside of it. Here are those frontal sinuses we mentioned earlier. And here's that crista galli of the ethmoid. And again, here's the three floors. You've got the upper floor here. And that's kind of got, it's got a little bulbous kind of section. That first floor is pretty big, or the third floor. This is the penthouse up here, right? And then we've got kind of this middle floor of the house called the nasal cavity. That's got a little closet space here. We've got the sphenoidal sinus. Okay, but we can see we've got a ceiling of the nasal cavity is also the floor of the cranial cavity. Okay, and then down here we see the hard palate, the maxilla. Okay, that's going to form the floor of the nasal cavity, but it forms the roof or the ceiling of the oral cavity. So we have three large rooms separated by a couple of bones. That's all. Okay. Again, you can see that sella turcica, that little saddle or groove of the sphenoid. That's where the pituitary gland sits. Sinuses. You could see how a sinus infection, right, way back here. The pituitary is your master endocrine gland. This controls pretty much everything that goes on in the body. And look at how close it is. It's within the same bone, right? It's protected by the same bone that also has a large sinus in the posterior aspect of the nasal cavity. So if this infection gets bad and it doesn't get treated, it doesn't get fixed, it doesn't resolve, that could lead to some issues, certainly. You can imagine with the brain. Okay. Frontal sinus is usually pretty straightforward and able to take care of. But yeah, this one back here, harder to get at. Oh yeah, you can see all these lines. There's the suture lines, big, deep, jagged suture lines. Yeah. The sphenoidal sinus, sella turcica. Again, a bad sinus infection back here could potentially lead to some serious problems with the brain. Thankfully, we do have this blood-brain barrier, so we do have this little foramen here and a couple other little foramen where the carotid arteries will bring blood into the brain, and so the brain is pretty safe as far as from infection. Of course, it does happen. This is maybe one pathway we could see why. Here's an orbit. You can see all of the bones that form the orbital bone. We have 7 of them. We've got the ethmoid bone that we've looked at quite extensively, and then the frontal bone forming the roof of your eye socket. Sphenoid kind of forms the back of it, along with the zygomatic, and then maxilla. Okay, so these are all bones we've talked about a little bit up to now. We do have a new one right here. It's a paper thin, tiny bone called the lacrimal bone. Very tiny bone. And this is going to be basically kind of the drainage system. It's going to have little perforations or holes. That's where the tear ducts and drain. The lacrimal bone. You're going to have tear glands that sit kind of out here in this soft tissue area. And the tear glands look a lot, or lacrimal glands, they look a lot like a shower head. Okay, and it just kind of keeps the eye lubricated. And then we have kind of the shower drain associated with the lacrimal bone. And that shower drain actually goes and connects a little bit with your maxillary sinuses before it finally drains into the nasal cavity. So that's why in an emotional state, when the tears get going, so we oftentimes everything blows up, right? So there's just a lot more fluid, and the drain is getting a lot of stuff in there, and uh, blows up the sinuses a little bit. So these next few slides, I'm going to zip through. You can again look at these on your own, but they just go through the disarticulated. We pulled them, and now you can see the disarticulated aspects of some of these. And you can see that zygomatic process. Here's a good view. You can see that kind of tunnel I was telling you about, where the muscle of the temporal bone comes through and attaches onto the mandible. Okay. The zygomatic arch, they call that. Zygomatic means cheek. We haven't seen that yet, but here's kind of a cool illustration of the sphenoid being removed or disarticulated. You can see the sella turcica. There's a couple of holes, the optic foramen. So that's where the eyeball holes, or that's for the optic nerve from the eyeballs that's going to head to the brain. So the pituitary and the optic nerves all travel around the same area. So we'll see this coming up when we get to the nervous system. We're going to look at the underside or the inferior aspect of the brain, and we're going to see the pituitary gland and what are called the optic nerves forming an X. The left eye is going to go to the right side of the brain, and the right eye is going to go to the left side of the brain. That optic X or optic chiasm, we're going to see is right in this area. So again, when we get to the soft tissue of the brain and start looking at that, you can relate it to where it's located within the skull. Here's the ethmoid bone pulled out. And again, we look at a kind of a front view or an anterior view of it. We can see a little bump, the crista galli, and then there are a bunch of little perforations called this is the cribriform plate. And then we have the perpendicular plate that helps to form that part of that nasal septum. Here's another view of, you can see again, this is where those little olfactory or smell bulbs are going to sit. So the sense of smell is going to come into the brain via those pathways. And remember, the ethmoid in relation to the sphenoid, they're next door neighbors. So we've got smells and sights going into the brain via similar pathways and in these same areas. And then here's the vomer by itself. This is the plow bone. Looks like a plow blade. And again, it helps to form part of that nasal septum. So you can see the inferior aspect of the nasal septum. So the ethmoid bone and that perpendicular plate come down, and then the vomer bone from the bottom connected to the floor of the nasal cavity kind of come up and connect and form that left and right nasal septum. Okay. Okay, and then here's the maxilla. So we're in the facial bones. So vomer is your first facial bone of this little grouping, and then maxilla we see is the upper jaw bone. We can see that large maxillary sinus in there, and then the part of the hard palate. And then your cheekbone, the zygomatic bone. Again, comes together, has the temporal process that comes together with the zygomatic process of the temporal bone. That's going to form that zygomatic arch. So the zygomatic is just from the edge of your eye, the lateral kind of canthus or little crook of the eye there. Just follow that straight down. That's your cheekbone. That's your zygomatic. Okay. And the palatine bone, that's just, again, at the roof of the mouth and the posterior aspect of the roof of the mouth. And then we've got the nasal bone and the lacrimal bone. The nasal bone is the bridge of the nose. That's that hard section that your glasses might sit on. And then here's the illustration of where those sinuses are located and the ducts and drainage. You can see the lacrimal ducts. This is, again, the drainage system for the eyes. The actual lacrimal gland is going to be up here secreting, not that far up, but right around in here, secreting tears, and then they're going to drain down into these areas of the nasal cavity, including those sinuses. So you can see the large frontal sinus and maxillary sinuses. Okay, those we can get to. Um, and then the ethmoid air cells or ethmoid sinuses, again, a little bit more posterior to the frontal and maxillary sinuses. And we saw that sphenoidal sinus and its proximity, again, to the pituitary gland. Okay. Well, I didn't have an image of it, but we talked about it a little bit, or an illustration. The mandible, that's your actual jaw, the mandible, the lower jaw. And again, that forms the movable joint with the temporal bone of the skull. That's pretty much it for the skull bones. The fetal skull, again, I mentioned how it morphs a little bit when baby's coming down the birth canal. And then what we end up with are little fontanelles or soft spots, and that allows the skull bones to form and accommodate the rapid growth of the brain. Because, as you know, relative body size, I mean, a newborn baby, probably at least like a third or more of the baby, maybe half, is just the head, right? So you got this like basketball on a toothpick, you know. So we have to grow into our heads. So now it's like, a tenth or a 12th of our body is the head. With a baby, it's not like that. So they have to grow into their head. Their brains, as you know, grow rapidly. So we do need to allow certainly some flexibility with the skull bones or the cranial bones. So we can see the fontanelles. Of course, we have the large one right on the top. That's going to be where again, the frontal bone and the parietal bones come together. That's that coronal suture. And then we have the sagittal suture going down the middle. And then in the base of the skull, there's another soft spot. Again, you can really see that lambdoidal look, that kind of arrow look. Okay, up arrow. And then again, this is part of that sagittal suture line of the parietals. This even has a pulse too, right? As blood going up. If when that fontanelle is really depressed, that's usually a sign that the baby is dehydrated a little bit. So we definitely want to get them going on more milk. Um, so yeah, it's naturally a little bit depressed, right? But then you can see it kind of poof, 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 kind of like a pulse, right? So, but when it's really depressed, I've seen some that, the baby's extremely dehydrated. And so you'll see that really depressed there. Anyway, you can see where the teeth, little buds are there too. Yeah, big old eye sockets. Another little soft spot, kind of where near that mastoid and where the ear holes are. All right. We're still in the axial skeleton. We're almost to the vertebrae. Before we get there, there is this little kind of looks like a set of vampire fangs. It's called a hyoid bone. That's the bone in the throat. It's basically suspended there by a series of ligaments. It doesn't articulate or move or form a joint with any other bones. Okay, the hyoid bone. This is one that the coroner might look at, or the medical examiner. The coroner doesn't really. The medical examiner who does the autopsies, they would look maybe to see if there's displacement of the hyoid to determine whether or not there was maybe strangulation involved with the victim's death. So we do see the larynx or voice box, kind of the pathway down through from the upper respiratory to the lower respiratory tract. This is kind of the junction where those two meet up. And so if the hyoid is displaced, it could certainly stop the flow of air, cause a little bit of a collapsing of the larynx, thus not allowing air to pass through. So maybe a motor vehicle accident too. We could see that um, happening. Anyway, vertebral column is next. So the hyoid isn't really part of anything. It is part of the axial skeleton because it is down the axis. The vertebral column is first up regarding our spots leaving the skull. We're going to see the vertebral column consists of three primary areas and then a couple kind of secondary areas toward the bottom or inferior aspects. So when we take a peek, the first thing we notice from a lateral perspective is we do have some curvature to the spine. Now, with a newborn, in the first several weeks of the newborn, they're going to have really just one curve, right? Because they were curled up in the womb, and so they have what's called just basically a primary curve. So as they start getting some of their muscles going and they start doing a little more, which happens fast, right? Some newborns right out of the gates, they're trying to lift their heads up and they're trying to do things. So what they're doing is certainly stretching. They were cooped up, but they're also establishing some of the more natural curvatures that they'll possess as they grow into adulthood or towards adulthood. We do see two anterior curves. Notice our little compass. We have anterior, posterior. So we're looking at the front or the anterior portion of the vertebral column. And again, we see a cervical curvature and then a lumbar curvature. So those are normal spinal curves in the posterior or the anterior direction. So we call these anterior spinal curves. Okay, so the cervical curve and the lumbar curve are considered to be anterior curves. And then we have a normal posterior curvature called the thoracic curvature and the sacral curvature. So the names of these curvatures also happen to tell us the names of the vertebrae involved. So as we move from that anterior cervical curvature, we now get a look at more or less an anterior or a front view, and we can see now we have 7 cervical vertebrae, C7. Okay. They do call the first 2 cervical vertebrae C1 and C2, but they also call them the atlas and the axis. So atlas is C1, axis is C2. And C2, or the axis, has a little axis called a tooth or a dens. Dens, D-E-N-S, like the dentist. Dens means tooth. And so we'll see on C2 or the axis vertebra, we're going to see a little tooth. And the atlas is going to sit right on top of that tooth. And then the skull is going to sit on top of the atlas. So you can see then the skull. You can see right over here the occipital bone of the skull nestles right in on that C1 atlas. Okay, so they call that the atlanto atlas occipital joint. Atlanto-occipital joint. Most joints are named for the 2 bones involved. We saw that already with the TMJ, temporomandibular joint, TMJ. Okay, and then we see with the atlas and the occipital bone, the atlanto-occipital joint that forms where the head sits on top of the spine. All right. So we can abbreviate vertebrae. We can abbreviate a vertebra with the first letter of whatever the group is, and then whatever the number of that vertebra is. So atlas could also be C1, axis C2. How are you going to remember the difference? Well, Atlas comes before axis in a dictionary. So just remember it that way. Atlas, AT comes before AX in the, they both start with A, I know. So now what do you have to do? You have to go to the next letter. So we go to the T and then the X. So the atlas comes before the axis, just like we would see in a dictionary. So C1, C2, and then we head down to C7. Okay. And then that is known as the cervical group. And they do form a little bit of an anterior cervical curve. And then the next batch we call the thoracic group. And there happen to be 12 thoracic vertebrae that form a little bit of a posterior curve. And then we get down into the lumbar, the low back area. We call those, or there are 5 of those, and they form the anterior lumbar curvature. These are going to, as you can see too, the bodies of the vertebrae, the bodies are going to be larger the further down we go. Okay. You see it forms a little bit of a broader base than what we see at the apex. And one of the main features of the vertebral column is to provide support to the torso and the upper body. All 12 of these thoracic vertebrae are going to have a rib pair attached. So the first rib pair is going to connect with posteriorly or toward the back with the first thoracic vertebra. Okay, so 12 pairs of ribs, 12 thoracic vertebrae. Okay. Breakfast at 7, lunch at 12, dinner at 5. Okay, so remember those numbers and certainly those groups. Cervical is in the neck, and you have 7 of them. Thoracic are in the mid section or the thoracic region. They articulate with the ribs. There are 12 of those. And then the lumbar or the low back, which notice they don't articulate with any of the ribs. There are going to be 5 of those. Okay, so these are all individual vertebra forming one long vertebral column. However, we do have a couple extras at the bottom or at the most inferior aspect. We see what's called the sacrum. Okay, the sacrum. The sacrum is roughly 5 fused vertebrae. So if I were to fuse 5 vertebrae together, I would get a sacrum. Okay. Notice too, the sacrum articulates with the appendicular skeleton and specifically the pelvis, even more specifically, the ilium of the pelvis. So we're going to look at this joint a little bit later, the sacrum and the ilium coming together, forming a sacroiliac or SI joint. And that's sciatic issues oftentimes come from the lumbar or the lumbosacral area. Okay. And then lastly, we have the tailbone. And the tailbone is called the coccyx, COCCYX. The coccyx is also a group of fused vertebrae. We would say there are probably 5 or 3 to 5 fused for the coccyx. Okay. Sacrum is pretty much going to be 5 fused, and we know that based on the holes and the ridges that we see with the sacrum. 1, 2, 3, 4, 5, and you can see kind of a break there, and so on down the line. We see the same thing with the tailbone or the coccyx. Okay, a couple other special features with vertebrae is that I'm going to come back to those too. Vertebrae are generally going to have a spine, what we call a spinous process. They're also going to have what we call transverse processes that stick out toward the side or in a transverse direction. They're also going to have a body. That's where the intervertebral discs are going to sit. And then we do see the hole for the spinal cord called the vertebral foramen. Now, there are two extra holes with cervical vertebrae. We see what are called transverse foramen. So if I were to give you three vertebrae to pick from, a cervical, a cervical, a thoracic, and a lumbar, and I asked you to tell me, is this a cervical, thoracic, or lumbar vertebra, you would be able to tell me without hesitation. And one of the main features of that differentiates a cervical from everybody else is the presence of three holes. Cervical are going to have three holes. 1, 2, 3. So right away, if it has three holes, cervical. Okay. C1 and C2, the special ones, the atlas and the axis, they also have three holes. You would recognize those independent from any other anyway, just based on their odd shapes. Okay. But here's the atlas. You can see it's got 1, 2, 3. It has a huge vertebral foramen. And then we can see the little groove or facet for the dens or the tooth. And here's that dens or tooth. As in a side or lateral view, we can also see the extra holes or foramen. So we go to the next slide and we can see the occipital bone sitting right on top. These are the occipital condyles, little bumps. They fit into these grooves, probably called fossas. A fossa, F-O-S-S-A, is a depression or a facet. Okay, so the condyles are going to fit, the bumps will fit into the grooves. Okay, that forms a joint, that atlanto-occipital joint. And then we sit so we've got this big ball, the skull, connected with a atlas vertebra. Then we just drop it right on top of the axis. We can see the dens here. That's kind of, again, like the axis that the skull is rotating on. All right. Cervicals, some of them from the side, they have more of a slanty, angular spinous process than we might see with the thoracic and the lumbar. But again, the three holes, that's a slam dunk. Boom, boom, and boom. Okay, does look like a giraffe profile a little bit, maybe too. All right. Also, cervical will have very tiny bodies as well, relative to a thoracic and a lumbar. How do you tell the difference between a thoracic and a lumbar? Well, one of the primary ways is certainly the body, or it will be slightly smaller. Even the body from a T12, the last thoracic, and the first lumbar, T12 and L1, there's still going to be differences. The body of the T12 will be slightly smaller than the body of lumbar 1. This is showing T10 and L3. So we can definitely, there's 11, 12, 1, and 2. There's 4 vertebrae separating these two. So obviously the body diameter is going to be a little more dramatic from one versus the other. So how would you tell if I gave you a T12 and an L1? Well, you're going to see smaller transverse processes that are going to have more of like a groove right in here. You can see this groove. We don't really have that groove as deeply notched over here. And we have a lot spikier, larger transverse processes with a lumbar. Remember, the ribs articulate with these. So the rib is going to plug right into this area, into this facet. This facet are going to help with, here it is here, the superior articular facets. That's for the vertebra that's above it. So when I set T9 on top of this one, it's going to have inferior facets that it's going to slide and glide into. And then, but anyhow, There are also grooves that we see where the ribs come in, and we'll see that shortly when we get to the ribs. Lumbar have a lot thicker, not only a wider body, a larger diameter, they also have a lot thicker body because, again, they're providing most of the shock absorption and the support from the upper areas of the body. Looks like a moose in a profile view. So we've got a giraffe over here and a moose head over here. I don't know what this looks like. Maybe a dingo or a kind of like a schnauzer. I don't know. They got the ears, maybe the eyebrows, kind of a puffy face. It's kind of like a dog. I don't know. Zurg from what is that? Ghostbusters. But anyway, lumbar, and we've got sacrum, and you can see they're fused, and then the coccyx. They snap that one apart so you can see them separate, but coccyx is typically going to be fused together. That's it for vertebral. We're moving right along. Okay, thoracic. The thorax is next. Just a couple things with the thorax. We have the sternum. We just have 3 parts to the sternum: the manubrium, the body, and the xiphoid or xiphoid process. So this little point is basically a big batch of cartilaginous tissue that's kind of hardened with a little bone kind of inside of it called the xiphoid or xiphoid process. So that's the sternum. And then we have all of these ribs attached to the sternum. We have 12 pairs of ribs, so 24 total. The first 7 pairs are called true ribs, and a true rib pair means it has its own cartilage called costal cartilage that comes in and inserts onto the sternum. So we can see 1, 2, 3, 4, 5, 6, and a 7th batch of costal cartilage. So those are called true ribs. The 8 through 12 are called false ribs because they do not have a true connection with the sternum. That's all. That's why they're called false versus true. So you can see 8, 9, and 10, they don't have a true connection with the sternum. They actually join up with number 7 right here, and then 7 has its own connection. Okay, so 8, 9, and 10. And then 11 and 12, they don't have any costal cartilage. They're still false ribs because they don't have a true connection, but they're also known as floating ribs. They just kind of float off of the 11th and 12th thoracic vertebrae. So know those numbers. Know the number of cervical, thoracic, and lumbar vertebrae. Know the number of total ribs, and then know so 24 total, 2 pairs of 12, and then know that the first 7 pair are called true ribs, and the last 8 through 12, the last 5 pair are called false ribs, and even more specifically, the last 2 pair are called false floating ribs. All right, and there you can see how that rib just kind of skivvies right in there along the thoracic. And again, we have these facets back here. Those facets that we saw are the facets for each vertebra stacked on top of of another. So the rib actually comes kind of along on the lateral aspect of the thoracic vertebra. That's it there. I just want to talk about a couple things real briefly with the appendicular skeleton. We're getting toward the end, believe it or not. So I do want to spend a few minutes popping up visible body and mainly the assignment, discussing that a little bit. And remember, next Tuesday and Thursday, I'll be in here hanging out. So I'll probably go through joints a little bit. I don't think I'm going to have time to really talk much about joints. I kind of have already, but there are a couple specifics that I do want to discuss. Between now and Tuesday of next week, you have plenty to do. But if you do get to the point where in visible body in your portfolio where you're doing joints or the lab activity, then you're ahead of the game. So that's really where we're at. So again, next Tuesday, I'll probably just go through a few things with joint specifics, and that's really it. All of that information again is in the slides, and you'll be privy to it certainly when you're working on your visible body. All right, next up we've got appendicular. I'll make this brief. We've got the shoulder girdle, two bones. First bone is the scapula. You've known it as the shoulder blade maybe. The second bone is called the clavicle or collarbone. So the collarbone and the shoulder blade are also known as the clavicle and the scapula, and they form the pectoral or shoulder girdle. And that's part of the appendicular skeleton. And we see the arm plug right into that pectoral girdle. Now, the scapula does have a couple of features you're going to want to take a peek at. The acromion off of the spine. The spine is the posterior aspect of the scapula. That you can feel if you follow your collarbone around, it just continues onto a bony kind of ridge. That's the spine of the scapula. So you can palpate the entire clavicle as it connects with this acromion process and kind of swings toward the back of the scapula. So anyway, we've got the acromion, we've got what's called a coracoid process. You can palpate that. It's kind of a sensitive little bump right underneath where the clavicle and scapula meet. There's a big bump here. If you drop down a little bit, there's a tiny bump right in there. It's a little bit sensitive maybe. Okay, that's part of the scapula. That's this bump right here called the coracoid process. And then we've got a groove called the glenoid cavity or the glenoid fossa. This is the shoulder socket. It's a pretty shallow socket. And then we've got a couple superior angle, inferior angle, and superior border, medial and lateral borders. Okay. So there, and then again, that spine. Above the spine, we have a supraspinous groove above the spine. Below, so supra means superior above, right? And then infra means inferior below. So anyway, infraspinous groove, supraspinous groove, it just means above the spine we have a little depression. Below the spine we have a depression. It just so happens, we'll see in a couple of weeks with the muscles, that's where the rotator cuff muscles, a couple of them are going to be located kind of in that area. All right, so anyhow, we could see the scapula and the clavicle kind of connected there. So this would be a joint, right? The scapula meeting the clavicle, that would be a joint right there. They call it the acromioclavicular joint or the AC joint. Not much to talk about with the clavicle. You've got the sternal end toward the sternum, forming the SC joint, and then the acromial end or the lateral end coming out here. So you have the medial portion, the lateral portion, then there's a middle portion of the clavicle right here. Kind of an S-shaped bone. It's flat, not a lot to it. Okay, and then the arm bones, you've got the humerus, the upper arm bone, and then the ulna and the radius as your forearm bones. The ulna, there's a lot of L's here. The ulna is going to form your elbow, and olecranon is the fancy word for elbow. Olecranon. Okay, so the olecranon is the elbow. That's the medical term. Okay. So that when we bend our arm, bend the elbow, it's the ulna coming up, decreasing the angle it forms with the humerus. The ulna is always on the pinky side. So ulna is on what we call the medial side. So in correct anatomical position, just like we see with our model back here, we've got palms facing forward. So the ulna are going to be considered medial. They're on the pinky side. The radius is going to be the thumb side or lateral of it. The radius is on the thumb side. So this is your radius and your ulna. And you could follow the ulna just by palpating it from the pinky, takes you right to the elbow. Or you can find the elbow, palpate down, it'll go to the pinky. That arm really, or that bone really just does this. The radius on the thumb side is going to be able to do radiating, or pronate and supinate, we call it. So again, radius on the thumb side, ulna on the pinky side. Radius is lateral, ulna is medial. Okay, we see a couple of bumps and ridges. Here's an epicondyle. That's another type of bump. Some folks get epicondylitis. They might get golfer's elbow or tennis elbow. So you can get lateral epicondylitis or medial epicondylitis. We've got two bigger bumps called condyles. Specifically, they're called capitulum and trochlea on the distal aspect of the humerus. So the distal humerus articulates with the proximal ulna, and a little bit of radius too. The capitulum, looks like the word cap, actually fits onto the head of the radius. So the cap fits onto the head. And then the trochlea goes with the ulna. They both end in A. Trochlea, ulna. Okay. Capitulum, the cap, fits on the head of the radius. Okay. So we see a styloid process again. Styloid, we saw up here with the temporal bone. We see stylus again with the distal aspects of the ulna and radius. Here's another fossa, or a groove. That's the elbow groove. Okay. Oh, and by the way, the ulna and radius at the distal portion, of course, are going to articulate with the carpal bones. You don't need to know the specific carpal names. Just know that you have 8 carpals in each wrist. Just know carpal. This is all you need to know about carpal bones. Carpal means wrist. You have 8 of them in each wrist. And maybe thirdly, know that they are short bones. Okay? Carpals, wrists, short bones. 8 in each wrist. That's it. Metacarpals, just know metacarpal means your hand. Okay? You have 5 in each hand. And we label them by Roman numeral. So first metacarpal, second metacarpal, third metacarpal, fourth metacarpal, fifth metacarpal. So the metacarpals are these here. Metacarpals. Okay. 1, 2, 3, 4, 5 of them. Okay. And then these are the phalanges, or the fingers. You have 2 phalanges with the thumb, but you have 3 in each of the fingers. So you have 3, 6, 9, 12, 13, 14. Okay, 14 phalanges in each hand. So 28 phalanges in each hand, or total up top, 28 phalanges total down below in the toes. So you have 56 total phalanges. All right. That's it with the upper extremity. Lower extremity, we've got what's called the pelvis, the hips, what they call the coxae, or the coxal area. We're going to see 3 different coxal. So each coxal bone is made up of 3 fused bones called the ilium, ischium, and pubis. Some say ischium, but a ch in Latin is a k sound, right? Like a chiropractor. Ischium. Ilium, ischium, pubis. Ilium, we'll come back to that. Ilium is the largest of the 3. The ilium makes up the bulk of the pelvic girdle, the bulk of the hips. Yeah. The posterior part of the hips, an inferior part, is called the ischium, and that is going to be your butt bone. So what you're sitting on is likely going to be your butt bone, or ischium. And as we come anterior, we have the pubic bone, or the pubis bone. Okay, the pubis bones meet and form a symphysis at the front or anterior portion of the pelvic girdle. So when we look at the pelvis, we can see the pubis bones are more anterior and they combine to form this little joint called a pubic symphysis. We also see so female pelvis versus a male pelvis, what we call the pelvic inlet is going to be much greater. So a baby has to pass through there, so the cup or the floor is going to be larger. There's an angle right here called the pelvic or pubic angle. The pubic angle or pelvic angle in a male is very narrow. In a female, it's going to be 90 degrees, maybe more. Right? In the male, it's less than 90 degrees. Okay. A couple things. Here's the biggest hole in a bone. We call it the obturator foramen. We also have the hip socket. We saw with the shoulder and the scapula, we called it the glenoid fossa. In the hips or the hip bones, we call it the acetabulum. And again, you guys are getting inundated with a ton of terminology. So hang in there. You're doing great. We're almost done. The last three of the leg or lower appendages, we have the femur, the largest bone of the body, heaviest, biggest, strongest bone. And then we have the shin bone called the tibia. Tibia is the shin. And then lateral toward the outside, we have what's called the fibula. Yeah, the fibula, that one's non-weight bearing. So that's primarily a bunch of attachment sites for muscles. Oh yeah, we see the tibia as the shin, and the femur articulates with the tibia. And we don't see the fibula over here. It's kind of off to the side. So folks who break a fibula, again, this is lateral. This is the outer aspect or lateral side of your lower leg. If that bone gets broken, we could put you in a walking boot because the tibia is what's bearing all of the weight from the rest of the body. Well, the tibia between these two bones, actually the talus and the calcaneus down here in your tarsals, they bear most of the weight, your ankle bones. All right, so anyway, you've got this big head and neck of the femur and the two trochanters. These are big muscle attachment sites. Okay. With the tibia, we've got and the fibula, we've got the two hammer aspects. They're called a malleolus. Malleolus means little mallet, which is like a hammer. So what you've called your ankle bones in the past, right? Like when you put your shoes on or put your socks on or whatever, there's those two bumps down by your ankles. You've got the bump toward on the medial portion and the bump on the lateral portion. Your ankle bones, right? You've all bumped your ankle bone, or you know what I'm talking about. Those actually are not your ankle bones. They're actually part of your tibia or your shin. So the one toward the middle is called the medial malleolus. So this is that big bump. That's part of your tibia. If you palpate or feel your shin and you follow it down, it takes you right to that bump. And then the lateral bump on the outside, if you palpate that, follow up, it'll take you right up. It kind of buries right into some musculature, but that's the fibula. So your ankle bones that you called them in the past, those are actually your tibia fibula combo, or the tib fib, we call it in the clinic. Medial malleolus, lateral malleolus of those two bones. And again, we've got the knee joint. There's the patella covering the knee joint. And then we've got the tarsal bones. Now you're going to have 7 tarsal bones in each foot. These are the actual ankle bones. The ankle, just like the wrist bones of the hand, we've got the tarsal bones down in the ankles. These tarsal bones are going to be, you need to know 2 for sure. The first one is called the talus. Talus is like the talon. That's where the tibia sits on top of the talus. Okay, so the tibia sits on top of the talus. So we can see the talus right there. Okay, it's the talus, the talon. And then underneath the talus is your heel bone, we call the calcaneus. So the talus and the calcaneus, those are the two tarsal bones you need to know. Talus, calcaneus. So your heel bone is actually an ankle bone. Okay? Tarsals are ankle bones. All right, so that's it for those navicular, cuboid, and cuneiforms. You don't necessarily need to know those. Know again, you have 7 tarsals. Tarsals are ankle bone in each ankle. So you have 14 total, 7 in each ankle. Okay. You need to know 2 specifics, the talus and the calcaneus. And then we have the metatarsals making up the foot, 5 in each foot. And then finally we have the phalanges, just like we saw up top with the fingers. Okay. Arches, this is just an FYI. This may show again why we have why heels might be bad. Again, they're putting the weight distribution isn't distributed properly between. There are 3 contact points. You have you can see the third one here. You have one here, the heel, and then we have the distal portion of the metatarsal of the 1st and 5th. So 1st and 5th metatarsals are strike points, and then the calcaneus. So those 3 spots are the ideal weight distribution strike points. Footwear, a flat foot or a bad arch, wearing heels, that alters the distribution of weight. So the metatarsal heads are now, instead of in this form, they're now in this form. And that can lead to spurring here, but it can also lead to, remember, the calf muscle is shortened, so the calf muscle is actually pulled up in an isometric position. That's going to cause stress right down here as well. Men and women skeletal differences. Again, we talked about the pelvis a little bit. Men, more like a deep funnel shape with a narrow pubic arch. Women, for females, have more of a shallow, broad pelvis with a wider pubic arch. So the male pubic arch. So the male pelvis is like this with a small, narrow arch. Female pelvis is more like this with a wider degree of pubic arch or pelvic arch. Okay, so you can see the pubic angle. See the angle is less than 90 degrees. It's probably about 60 degrees. Female, that angle is a 90-degree angle. Okay, we'll stop there. And so articulations, joints, I'll talk about those a little bit next Tuesday. I know I said it's optional, which it is. Every class really is optional. I did say I'm not going to go through anything new. I was hoping I wouldn't. I was hoping I'd get through everything, but man, we basically just did 3 chapters in 2 days. So we're left with articulations and joints, chapter 9. So I will go through that Tuesday morning. I'll certainly record it, so you don't have to worry about that if you can't make it. Now, I do want to go to visible body and assignment portfolio. Take a peek at that for just a couple of minutes. Okay. Again, we had trouble pulling it up last time. I know it was, but I've left it open, so it should be fine. But again, the beginning is 77 kind of definitions. Again, with definitions, you can use location, landmarks, whatever. These are for you. They're your descriptive terms to help you. So I generally don't recommend just copying and pasting definitions from OpenStax or Merriam-Webster.com or whatever you might be using. Copy and pasting definitions in. I know some of you do it. It's what I can't. I'm not here to um, micromanage anybody, so I'm certainly not here to try and catch somebody doing something maybe they shouldn't be doing. I mean, I don't know. That's subjective in my book. So my point is, if you do copy and paste them, that's fine. But what I would do is trim out some of the verbiage that's in what you copied and paste and just isolate it down on a couple of key points. Because when you see X word and it has a 15-word definition, there might be 4 words out of that 15-word definition that really apply and are appropriate and are kind of like trigger words for you understanding the original term. I think all of you know what I'm talking about. So keep that in mind. This is not busy work. It's no, and if you're just copy and pasting definitions, you've now made it busy work, because now you're just doing busy work. Okay. If you're actually copying and pasting, or you're actually reading definitions, typing in a couple of things, or maybe you don't use anything, maybe just you're ready, you go in and you just read down the list and you're like, okay, I know this one, this is what it means to me. Okay. I'm not looking for exact, this is Mr. Yoakum's definition, or this is OpenStack's definition, or this is who anybody, no, this is your definition, or linkage, or a way that you're going to understand the terminology. How you do it, totally up to you. But if you're looking at it to memorize and to understand for long-term use, again, the more you work with it, I don't mean the more time you spend with it, but maybe just the approach and the difference in how you do it, it will help you understand them better. So anyway, how you guys do your thing is how you do your thing, but that's my recommendation for those. This little section here, this is the same word list that you have over here, General A&P Skeletal System Anatomy ID. That's in your weekly units, week 5 section. There are a couple things that I also wanted to remind you of as well. When you go into your Skeletal System week 5 folder, again, you're going to have the chapter textbook link. The exam's done. I'll have that uploaded to probably this afternoon between classes. None of you are ready to take it anyway, but it's ready. It's done. I finished that this morning. So that will be uploaded, and you'll see exam down here, and then the links. But you've got the axial skeletals with key, and an appendicular skeleton with key. You may want to check these out. It's a couple of PowerPoints with photos from the lab. I think these were from the Kenosha lab. But anyway, they're photos from the Kenosha lab models, pointing with stylus to different features on the axial skeleton and then the appendicular skeleton, and then the answer at the very end, the key telling you which slide, what is on each slide. So check those out. Those are very helpful. This skeletal, so under direction for this section, skeletal system identification, that's this list. That's the same list that you would see in the portfolio. So we went through all of these today, and then you're going to go through visible body. So this is where I was trying to get us to. Access visible body, complete the modules, and use the anatomy ID found under the skeletal systems tab. So that's this. Let's go into visible body, and we see under my assignment, or under assignments, when I open up skeletal system, I have a lot of stuff going on here. So I only want you to focus on the first 3. So that's what that little screenshot that's thrown in there is showing you, just these top 3. That's where your focus needs to be. Don't do, I mean, you could, if you have augmented reality capabilities with your phone or your tablet, then by all means check it out. Pathologies, that's a very interesting section. It goes through some fascinating stuff about bone pathology. Don't worry about any of that stuff, though. You can if you want. You can do whatever you want, but this is not required, I guess what I'm saying. But I would recommend you going into modules and practice quizzes. And it just like we've seen before, if we open up Introduction to Skeletal System and Joints, this is the Anatomy Physiology app. It's going to take us into that app. Okay, it just looks just like what we've seen before. Okay. And just start right up at the top. Almost there. I know it does look like a lot. It really isn't. There's just one image on each of these pages. Okay. We made it. All right. So skeletal system overview, axial appendicular skeleton. These are very short, very brief. Gets into bone types, flat bones, long bones, short bones. Again, very brief. These are just basically, see, look at it, how slow it goes. As soon as I get visible body going. All right, well, I'm going to exit out so it doesn't keep doing that. So anyway, please go through that and look at that. You'll be blown away at how awesome it is and how much it's going to help you to understand what we're doing. If you don't get to the joints section between now and Tuesday, that's fine. We're going to talk about joints next week on Tuesday. There are a couple practice quizzes in there that you can take. The anatomy ID, if you click that, this takes you to the full skeleton in the regular anatomy, Human Anatomy 2020 app. So we click that, it takes us to that Human Anatomy 2020 app. And I probably goofed up just by opening that, and it's going to slow everything down. So anyway, you know what I'm talking about. So go in there and check that out as well. And then lastly, you're going to want to do these graded quizzes just like you did last week and the week before. There's a handful of graded quizzes. Half of them are multiple choice. The other half are dissection quizzes. So you've got roughly 2 weeks to get all this done. It's not due until the 13th, 14th, right around there. So there is plenty of time for you to be working on this. And again, I want you to get caught up with your previous stuff as well this weekend. Next week is kind of your off week to get caught up on everything, or maybe you're doing that this week. I don't know, but the only thing new I guess I'm going to introduce you to is a little bit on joints on Tuesday. It'll be a short session. It takes maybe about a half hour at the most to go through it. And then from there, I'll open it up to you guys if you have questions, if you want me to go through a couple of other items. If you don't come at all on Tuesday, that's fine too. That's totally up to you, but I'll be in here and I will do a lecture to finish out our PowerPoint, just talking about chapter 9 and joints. And then I'll upload it into YouTube so you can watch it that way. And then again, I'll be in next Thursday as well, just for Q&A or for any questions that you might have. But anyhow, here's the rest of your portfolio and visible body. Again, pretty straightforward. Some of these I'm just looking like for the bones of I just need the group name. Remember with the ankles, unless it was pointing directly to the talus or the heel, then you would just write tarsals in there. Okay. And again, what vertebra is this? 1, 2, 3 holes. Boom, cervical vertebra. That's all you need to put. You don't need to put the specific cervical. Okay. So everything's in there. You'll be able to go through and take care of biz. And then at the end, gets into our case study once again with and then how are the systems related, right? Nervous system. We talk about the skeletal system protects the nervous system. for one of the main features, but it's also a pathway for some of the sensory to flow, right? So we saw that cardiovascular. I mean, that's evident by now. One of the main features of bone, of course, is the production of blood cells. So anyway, you should have no trouble with those. And then, yeah, Paul, he's still struggling. So there's a couple questions about Paul's continued struggles. So that is that. I'm going to stop recording.